All right, then. Well, the time is now 7:03 p.m. I wanted to take a moment to welcome you all to today's virtual town hall event, Enhancing Awareness, Increasing Participation of Black Women in Cancer Clinical Trials. My name is Ryan Mullen. I'm a community cancer control specialist at Rutgers Cancer Institute of New Jersey. I'll be doing tech support today. Before we get things started, I just had a couple of housekeeping rules to go over. If you can, we do encourage you to keep your cameras on during this session, as we'd like to make this feel like more of an intimate program, similar to how it would be in person. If you do have any questions or comments throughout the program, please feel free to enter those into the chat. I'll be monitoring the chat throughout the presentation and will alert Dr. Omene, Dr. Toomey, and Dorothy Reed of all questions that are entered in the chat. You're also welcome to raise your hand using the Zoom function at any time, and you'll be given the floor to speak. With that, I would like to pass the floor over to Dr. Coral Omene, Dr. Kathleen Toomey, and Dorothy Reed.
So good evening, everybody, and thank you for joining us tonight for this, what we hope will be a dialogue, a conversation regarding why we think it's important for Black women to participate in clinical trials. And I have today with me my esteemed colleagues to join me in having this conversation with me. So for those who may not know who I am, my name is Coral Omene. I'm one of the breast medical oncologists at Rutgers Cancer Institute of New Jersey. We are a NCI designated comprehensive cancer center. And as the name suggests, we do a lot of clinical as well as translational and basic science research for the purpose of trying to improve upon what we can for patient care with regards to cancer. And so we do a lot of clinical trials in our institute and our health system. And so I also participate in clinical as well as translational research. And I'm happy to speak with you today about this very important topic. And I have my colleague, and I will have them introduce themselves as well. Go ahead, Dr. Toomey.
Hello, everyone. Thank you for coming tonight. I'm Kathleen Toomey. I'm a medical oncologist at the Steeplechase Cancer Center at Robert Wood Johnson, Somerset, and I'm medical director of the Cancer Center. And we do clinical research in the community, along with the Cancer Institute of New Jersey.
Excuse me. Hello, everyone. I am Dorothy Reed. I'm a breast cancer advocate. I'm co-founder and president of Sister to Sister, which is a nonprofit breast cancer organization serving minorities and underserved women. Thank you so much for joining us tonight. I'm glad to be on this great panel, Dr. Toomey and Dr. Omene, the best two doctor oncologists in New Jersey.
Thank you. So moving on to the next slide. Before we proceed, we want to just take a moment to acknowledge the support for this program is provided by the V Foundation for Cancer Research in partnership with ESPN. So thank you to the V Foundation for your support, for your mutual mission and project that everyone agrees is very important. So thank you. Next slide. So I thought we would start off by having a brief overview about why this is an important topic to begin with, okay? And then we can delve into questions afterwards. So as of today in the US, about 280,000 women will develop invasive breast cancer every year. And unfortunately, over 40,000 of these women will die from the disease. It is the second leading cause of cancer death in women after lung cancer, but the leading cause of cancer death in Black women. From about 1989 to 2015, breast cancer death rates decreased by about 39%, which translates to about 322,600 deaths that are averted breast cancer deaths in the United States, which is great. During that same time, death rates decreased actually in all racial and ethnic groups. However, Black women continued to have higher breast cancer death rates than non-Hispanic white women by up to 40% higher. And if you go on to the next slide, you'll see this depicted graphically. On the left side of the graph, this represents female breast cancer survival by race and ethnicity. You can clearly see, compared to the green line, which is the line lower, representing Black women, all of the other races, all of them, non-Hispanic white, Native American, Hispanic white, Asian American, Native Pacific Islander, they are clustered higher in terms of survival, some lower than others, obviously, but it's clear that Black women significantly have less survival than all of the other races. And when you compare directly to white women, it's actually 40% higher in terms of death rates. On the right side of the slide, you'll see that although the incidence of breast cancer has over time converged and is about the same for Black and white women, the mortality rate, that's the death rate on the lower part of this graph, you can clearly see that when there was a decline in mortality starting from the early 90s, obviously due to better screening, due to better treatments, which led to this decline in death rates in general. However, there was still this gap between Black and white women, where there's higher death rates, significantly more so for Black women compared to white women. Next slide. So we know that the reasons for these disparities is multifactorial, it's just not one thing. But we also know that treatment, especially those that arise from clinical trials, are a key way in which we can help mitigate these disparities. So what are clinical trials? The definition in general is a research study that tests how well new methods of screening, prevention, diagnosis, or treatment of a disease are in people. They're typically the final step in a long process that begins with many years of research in a lab, and then in animals, and then in humans. There are different kinds of clinical trials. They test the safety and benefits of new treatments, also new combinations of drugs, or new doses of standard treatments. They tend to take place both nationally and internationally in many types of medical centers and hospitals, in the community, in large academic centers. It can be funded by a single agency, like the governmental agency, like the National Cancer Institute, for instance, or by pharmaceutical companies. But what is clear over the many decades of doing clinical trials, that significant improvements in breast cancer treatment has been made over the years due to findings from clinical trials. So when we speak specifically about diversity in clinical trials, this is why it's important. We have shown that Black women have significantly higher breast cancer death rates compared to white women. We've shown that clinical trials are important in solving the differences that exist in cancer healthcare between Black and white patients. Unfortunately, though, Black women are substantially underrepresented among cancer clinical trials. And this is for a multitude of reasons which we can discuss later. It includes issues of trust, experimentation, communication issues or barriers, access, lack of access, for instance, tend to be the most commonly identified barriers. And so consequently, given their lower participation, any positive outcomes from such clinical trials may not be relevant to Black patients. So it's important to have clinical trial participants be similar to that of the general population, so that any development of new drugs or interventions from these clinical trials are effective for everyone in the population. And I want to highlight this very key point of why it's important that everyone participate. And I'm going to use this clinical trial as an example. This is a clinical trial designed for Black women with breast cancer. This is a study from a large cooperative group called ECOG, titled Prospective Validation Trial of Taxane Therapy. Taxane is a type of chemotherapy agent that we use in breast cancer, is commonly used. And it tends to have a side effect called peripheral neuropathy. Okay, peripheral neuropathy, for those who may not know, symptoms of numbness and tingling in the hands and feet and can cause pain. It can be debilitating. It can either be mild or severe, to the point where people cannot feel their fingertips to button their shirt or to hold a spoon or a pen. So it can be quite debilitating. And so they carried out this study to analyze some of the data from their previous breast cancer trials. And so to come up with this intent of the study, which is to reduce the increased risk of chemotherapy-induced toxicity for African-American patients with breast cancer by identifying which is the preferred taxane chemotherapy that is based on the potential for being efficacious, as well as minimizing toxicity that can be used for cure for African-Americans with breast cancer. So just to reiterate, it was specifically designed for Black women with breast cancer. And on the next slide, you'll see that this is the schema of the trial. So women who self-identified as African-American, Black, or of African descent that had early stage 1, 2, or 3 breast cancer, of course, were newly diagnosed with no previous treatment, and also did not have pre-existing neuropathy, were eligible for this study. They were randomized to 2 arms. So depending on the type of taxane chemo, either paclitaxel or docetaxel. Once again, these are commonly used in the breast cancer regimen. And so depending on which one that patient was going to receive, then they were randomized to those arms of treatment so that we could then study these patients based on the type of taxane they received. And so blood samples are drawn for them, these patients, and they are followed over time. So these blood samples are sent for analysis. And so on the next slide, this analysis is based on the rationale of the study. So what is underlying this increase in taxane-induced peripheral neuropathy in Black women? So
from South and Central America were killed.
I may have to ask people to mute, please. I hear some conversations in the background. If we can. I think Karen McCombs has a question that she can't hear audio. Perhaps Ryan may help her with this, but if you could please mute everyone. Okay, thank you. So just to go back, the underlying reason for the taxane-induced peripheral neuropathy for Black women, you can see clearly in this graph. When they did the analysis from their previous breast cancer trials, when they went back to analyze the data, they found that when you looked at African women who, to look at women who complained of peripheral neuropathy, those who had either a rare variant with variant like mutation in SBF2 had a higher percentage of neuropathy, 65%, as you can clearly see in the blue bar graphs. And then there were other common mutations, like for instance in FCMR, that were found to have up to 49% for these patients to have peripheral neuropathy. So then they were able to categorize these patients into either high risk of taxane-induced peripheral neuropathy or low risk. Okay, so those with high risk would have the genotypes FCMR GG or SBF2 mutations, and those with lower risk had the wild type versions. And so now they are trying to look forward in real time to see if patients that are now being detected, so when they are enrolled in the trials, they look for patients that have these mutations to be able to see, can they, actually detect these patients with, if they, then present or complain with higher incidence of neuropathy, because then you can foresee how then you could then intervene on this patient early ahead of predict that they would have neuropathy, and then be able to hopefully intervene and prevent or decrease their neuropathy symptoms. Now, why is it important? Next slide. So this is just summarizing the rationale of why we use taxanes, because it reduces rates of breast cancer recurrence, and because African Americans have higher risk of experiencing this taxane-induced neuropathy. The point of this, though, is click next, Ryan. The point of this is that, as you can imagine, we do this in the clinic for patients who are complaining of neuropathy symptoms. The point is to try to dose reduce the chemotherapy drug, right? Because we want to be helpful. We don't want these patients to have worsening symptoms. And this is standard, to dose reduce the chemo agents. However, this is worse for African Americans, as I'll show you in the next slide. This is a key slide to know, important. This is a slide on the disease-free survival. On the left is disease-free survival for white, Caucasian, or those of European ancestry. And on the right is those of African ancestry, right, for these patients. What happens when we dose reduce? When we think we're dose reducing for everyone, to help mitigate their symptoms, for Caucasian or those of European ancestry, it doesn't affect your survival at all, whether you dose reduce or you don't dose reduce. But look at what happens on the right for Black patients, Black women. Those who have their chemotherapy dose reduced have worse survival outcomes, as you can clearly see in the red on the right. So this is an example of why we cannot use the same brushstroke for everyone. We can't
Sorry, everyone. I think Dr. Omene froze for a second. You may have lost connection, so we're just going to give her a moment to get reconnected. Yeah, she just left the Zoom call. So yeah, we'll just hang tight for a moment. Does anyone have any questions for Dr. Toomey or Miss Dorothy Reed while we're here?
Or did Dr. Toomey want to say anything about clinical trials while we're waiting?
Well, looking at the slide that's up, I mean, it's really it's pretty scary, right?
Mhm.
Dorothy, you and I have lived through this change in survival for women with breast cancer. And we've seen the changes over the years, that every year we do a little better, a little better, a little better. There's no cure for cancer. There are many small steps that you take. So when I see a slide like this that shows a difference between the disease-free survival for Caucasian women and African American women, it's very worrisome. I want the curves to go up. I don't want the curves to go down.
Mhm.
Of survival. So we see these small changes, but over time, these small changes really may have made big changes in women's survival. So clinical trials informing us how to best practice, right? We all have ideas, right? I think this drug might be a little better tolerated than that drug, but that's just my experience. I need to know from science, from the experience of many women, and that's what clinical trials are all about, right? Bringing in many women. When we first started giving chemotherapy after surgery, we gave it for 2 years. So there were women in the clinical trials that took chemotherapy for 2 years, and then they took it for 1 year, and that was just as good as 2 years. And then they took it for 6 months, and that was just as good as 1 year. So, we don't want to give too much. We don't want to give too little. We want to give just right. And the way to find out what is just right is to continue to do clinical trials. But if I am in a group where I'm not represented in the clinical trials, then the information may not be correct for me. And that's what we really worry about. You know, in the old days, it was mostly men in clinical trials, not for breast cancer, of course, but for other cancers. And then there was an age that you couldn't be over a certain age and be a clinical trial. And even today, you have to be in a certain, you have to have a good kidney function and good liver function and good performance status. And then we turn around and give the things that we've studied to people who don't have good kidney function and good liver function and good performance status. So, you know, I keep saying this every day, every year, we get a little better. And if we keep moving the ball down the field, you know, we'll get to a cure for everyone. And that's really what we're looking for, right? A cure for everyone.
Hello, everyone. Can you hear me?
Now we can.
Well, that was so weird. That doesn't typically happen. I just got dropped completely. So I apologize for that technical issue. But it sounds like Dr. Toomey was maybe taking a question or.
We were just talking about I was just talking about your slide that's up, that it's very scary for a practitioner to think if I decrease a dose of drug for a patient, it's going to affect their survival, and how important it is to have these trials to tell us these things.
Exactly. Exactly. And so I really hope that impresses on people, because, you know, if you understand that the clinical trials, all of the drugs that we use that, you know, come to be FDA approved and become standard of care, they all resulted from extensive clinical trials showing the efficacy. But we use it for everyone, at the dose for everyone, you know, whatever biomarkers were, you know, were vetted in those trials, you know, we use it, and because that's what we've got. But we actually don't know if it applies to everyone in the same way. And that's why clinical trials are important in terms of representation. So the more the trials reflect, you know, the population in terms of the percentages and the, you know, of the patients, just think about it. If you know, clinical trials, a Black woman, single digits, low single digits, you know, sometimes some of these practice changing trials will come out with drugs that in the recent years, and you look through to see the percentage of Black women in those trials, and you see 2% and 3% and 4%. So do we think that this really applies? We don't know, but we know we apply to everyone because that's what we've got. And then there are cases where you see, for instance, in this data that I showed you, that it really does not. And so we should really think carefully about what we do. And so I hope that this next slide, I think this may be the last one, because I really want to make this a conversation to take questions from the audience, and because I'm very sure that people have beliefs and you know, there's some questions or you know, information they don't know if it's correct or not. The stuff that they may have heard, no question is too small. You know, we're here to have this conversation to help educate, increase awareness, talk about why it's important, and hopefully when you leave here today, you'll have a better appreciation of clinical trials, especially, and why it's important for our population to participate. So I'll open the floor. Feel free to raise your hand. Ryan will call on you, or you could put your questions in the chat.
Before we get started, I would like to just add that meetings like this, Zoom meetings, whether in person or on computer, is so important so that our community can get used to hearing the word clinical trial. What we're asking you at this time is just to be open and listen to the breakaways they've made in cancer treatments, the studies that they're doing, how other ethnic groups are taking part in it. We know our history, we know what's happened in the past, but everything changes. So just keep in mind that, again, we're in a time of change. As we grow, we change. If you think back to the 70s, and I'll go back to the 70s. That's when I started working at AT&T, and typewriters were in, and I could type 80 words a minute with no errors. That's why I got hired on the spot. But if I had of just continued to say, I'm just going to keep typing, I would be out of the job, because one day I came in and there was a computer on my desk. So I had to change, and you have to adapt. The same thing happened with, there's so many things, the TVs. At one point, everybody was buying those huge TVs, took 3, 4 people to carry them up the steps. And now you can buy a 50-inch and almost carry it by yourself. We adapted. We didn't say, oh, we want to keep this same TV. You adapt, you change. The last illustration I'll give you is with the cell phone. Some people didn't even know you needed a cell phone. Who would want a cell phone? You know, what am I going to do with it? I think everyone, including children, got cell phones. We adapted, we make changes, okay? Even with your paycheck, you used to get a paper copy. You know, every on Thursdays, the banks would be loaded with people in line, cashing their checks. If you get hired now and wait for a paper check, you may never get paid. Everything has changed. Medical science have also changed, okay? Years ago, there was Tuskegee. We was misrepresented. We were used as sometimes guinea pigs, as people want to say. But a lot of changes have been made. Matter of fact, when President Clinton was in office, he had a lot of the Tuskegee people come, and he actually honored them, trying to, you know, I guess not cover up, but trying to acknowledge that we know things weren't done properly. Now things are done a different way. There have been changes made. And so with this conversation we're having, we're trying to show you some of the changes, show you some of the benefits from getting in a clinical trial, and just say next time you're offered to take part, to listen, communicate with your family, and start a conversation around clinical trials. There's a lot of African-American women, including my daughter, not sure if she's on the line, that have taken part in a clinical trial. And so, and a clinical trial is not the end. Sometimes it can be part of your treatment. Sometimes it can be the beginning. So just keep in mind, clinical trials are not a death sentence like we used to think they were. So if we have any questions.
I think you went through a lot of the myths there, Dorothy. So maybe we can hear from people what myths or beliefs they have heard.
Hi, this is Sharice Toppin. How are you? So I am a 7-year breast cancer survivor. I did partake in a clinical trial at CINJ. And I guess just a comment, when the trial was presented to me, my first knee-jerk reaction was, oh no, I am not going to be that guinea pig, because that is passed down through generations. But I will say that, you know, the treatment that I got being in the clinical trial and the attention I got was unlike any other. My question is, when is a clinical trial deemed successful? Like, what do you have to reach? How many patients have to be enrolled for you to say, this works, we found that this works on African-American patients, and we're going to roll it out? When does that happen?
So great question. So clinical trials, they're complex. They're complex, but they're based on certain criteria. So when people design clinical trials, there are certain objectives and endpoints. That's the goal of the trial. So based on that, then you typically have biostatisticians that work with you in designing the trial to say, if you reach this certain percentage of this objective, it's deemed a success. Maybe if you're comparing 2 different drugs or one experimental investigational drug versus the standard of care, and one could say, based on the number of patients, this is why statisticians are very key in helping us design the trial, because how will we know it's successful? there has to be an endpoint and there's a way to meet that endpoint, right? And so based on the objective, based on the outcome you're looking for, if it's a numbers, the statisticians will say, based on enrolling this X amount of patients, if you say reach a certain percentage, of this outcome of say, for instance, if we're looking for complete response, if we give patients chemotherapy before surgery, how many of those patients or reach a complete response in the breast even before surgery, that makes it say a success or an improvement over the next one. So the statisticians are key in helping making this calculation. And so then you do analysis, you assess your data as the clinical trial moves forward. And once it is met, it's then deemed a success, positive outcome. So that's actually just one way of figuring out in a trial if you've met your endpoints. There's some endpoints that are not met, and there can be reasons for that. But it's typically tied into the objective, the goal, because there are many different types of trials. There are treatment trials, they're all, device trials, there are all kinds of trials. But if we stick into, say, treatment trials, there's treatment for early stage, there's treatment for stage 4. And as you can imagine, some of those outcomes would be different, right? It could be how long it is before someone progresses on your disease in your stage 4, which is a different, question than say in the early stage when you're going for cure. So it really is tied into the objective designed in that trial. And then statisticians help you determine when you have met that goal. And there's typically designated times when you have to maybe pause the trial to do what we call interim analysis, because you don't want to just keep going and going for years and not know if what you're doing is working, because then that would be unethical, right? If it is working really wonderfully, which happens sometimes, where in an interim analysis where you pause the trial to investigate the data you have collected so far, sometimes you have to stop the trial right then and there because you have exceeded. It's been such a positive outcome that now it's unethical to continue to enroll patients and give them the other treatment, right? So then you have to stop it so that everyone can get it. So that's just sort of, one way, some of the ways in which we try to assess when you've met your goals. Dr. Toomey, were you about to say something?
Yeah, so I participated in a clinical trial called the P1 trial. And, asking how many women, it depends on the trial, but this trial took 13,388 women, and they were women without breast cancer who were at high risk, and divided them into 2 groups, 6,000 and so many on one side, getting tamoxifen, 20 milligrams a day, and the other group got a placebo, got a sugar pill. That trial was to go on for 5 years, but they stopped that trial in 4 years and 8 months because they saw a greater than 50% reduction in risk of breast cancer in the women who got the tamoxifen. And they didn't feel it was ethical to continue the trial and not let the other women know. So there are data safety monitoring committees that will stop trials if they're successful, and they'll stop trials if they're not, right? If they're not seeing a very big difference or any difference at all in the experimental arm, there are upfront, and all of this is upfront, right? We all decide upfront what percentage of betterment we want, whether it's 1%, 5%, 100%, whatever it is. Those things are decided before the trial starts, and then everybody gets monitored. I always tell my patients on clinical trial, you're going to be watched very closely by very many people. And I'm happy for that. I'm happy that I have a group of research nurses and statisticians and principal investigators and co-investigators that we're all watching these patients very carefully. I've also been chair of an institutional review board at the hospital, and the institutional review boards are there to monitor so that we don't have problems like we had before with clinical trials. So any adverse reactions, people are watching very, very closely to prevent those things from happening. But in breast cancer, clinical trials are usually hundreds of women, maybe even thousands of women. Other solid tumors. Other cancers are less. But because we have so many breast cancers and women have been so good at participating in breast cancer trials, that's why breast cancer is really a model for all the other solid tumors on how to do trials and how to treat patients.
That's exactly right. That's exactly right. So patients are typically very closely monitored, and they get, top level care. Not that we don't care for our other patients, but these trials are designed to be very careful in terms of monitoring, especially as we assess for safety, so that there may be, more hospital trips perhaps for assessments, more blood draws and what have you. And while we acknowledge that that's a positive, I have had that come up as an issue for some people. They look at that as a barrier because they may not be able to come for so many hospital visits and do all of these sort of more complex follow-ups that a clinical trial may need. And I wonder if anyone has, been in that situation or heard about this, maybe has acted as a barrier for them to participate in clinical trials, because we do know that there's some real life barriers that could be a problem for some women sometimes, but we want to encourage people that we actually have and can help. If you don't ask, or volunteer this information, you may not know that we can help with some barriers that may be of an issue. If it's transportation, for instance, that people may have problems with getting there, having so many trips, we can help with that through social work and through some of the resources that we have. And so I want to, just put that out there that, it is acknowledged that some of the benefits of the clinical trial may actually act as barriers for some patients, but we help in any way we can. So I want to really make that point, but I wonder if anyone has
Had some other questions there, Coral, I think, right?
Yes, we do have a couple of questions in the chat. If you'd like to unmute yourself, Charlotte, I saw that you were first. You can, feel free. Otherwise, I'm happy to read it to Dr. Omene.
So I see it.
Hi, this is Charlotte, right. I had asked how do Black women find out about the clinical trials that are going on? Because I don't recall any being mentioned. I'm currently I guess a survivor from 2014, but I don't recall any of the doctors mentioning them to me. Maybe there were none, but just wondering.
That's possible. It depends on the cancer center that you go to. Large cancer centers tend to have clinical trials, and also even some community cancer centers, affiliated with academic centers, tend to have the trials open there. So in terms, I can speak for our health system that Dr. Toomey and I are working, and that Ms. Reed is very a part of. We have clinical trials, and there is a slide later on during the wrap up that I will show, I'll put up for contacts in our health system if you want to know about clinical trials. And on our website, it's right there. You can click on clinical trials and it will pull up for you to find any trial you want, and it's all there. But if you want more information about specifics, there is a contact number we have on the slide towards the end, at least for our center. And I think typically large cancer centers, if you go to their website, they tend to designate an area in their website for information to clinical trials, because this is a big part of cancer center and their treatments that they offer. And so if you have a contact number for that center that you're thinking of going to for clinical trials, they can then guide you as to what they have, what treatment options they have. But they do tend to have, sometimes they may not, and sometimes they may say, oh, this trial is open in this center or that center. And if it's sort of near you, some people drive an hour, 45 minutes, an hour, to talk to us. And then they can decide if they want to participate in the trial, at our center. So there are different ways of going about it. But, if you have a center in mind, check their website, and that section, there's usually contact information, and we will have ours up at the end as well.
Okay, great. Thank you.
Of course.
And we have another question in the chat from Mercy. Again, Mercy, if you'd like to unmute yourself and ask Dr. Omene and Dr. Toomey, feel free.
Well, my question is actually in line with what the previous person asked, and that is, at one point, should anybody know to attend the clinical trial?
So I would say, well, what we hope for is that each and every patient, each and every time they're seen, they are considered for clinical trial. And what do I mean by that? My research nurses, I just heard these numbers this week. I was a bit shocked at them, but my research nurses will go through 600 to 800 people a month to get 3 or 4 on a clinical trial. It's not necessarily so easy because there are inclusion and exclusion criteria in clinical trials. But what we try to do is that when we have our multidisciplinary team meetings, that we look at each and every patient and say, what trial might we have for them? I really look at my patients, especially at the time of new diagnosis, or at the time when they have progression of disease. Those are the important times that I think about clinical trial. But there may be a clinical trial that has something to do with quality of life. A blood trial. We had a blood trial looking at different parts of DNA, for example. And so from a community point of view, I'm looking for a trial that will help the next generation of women, and hopefully help the women who are participating in it. But it's really about gaining the knowledge to continue to do better, whether it's better, more cures, or it's better treatment like this trial about peripheral neuropathy to help prevent that, or, and asking your healthcare provider, do you participate in clinical trials? I think is another very good question for you to ask, because you know that people who are participating in clinical trials are looking at the latest data and know, the latest stuff going on. So I think that's an important question for people to ask.
I want to
So you're
that.
saying, excuse me, I'm sorry to interrupt.
No.
In a sense, you're saying that when somebody is diagnosed and starts treatment, that's a clinical trial going on right there.
Yeah, absolutely. I think those are the important clinical trials. We don't wait till there's nothing else out there. I want to have the brand new thing that's going to be the next best thing next year or in the next couple of years. I want to have it today for my patients. I want to be ahead of the game. So yeah, right up front. Absolutely.
Absolutely, I second that. So there is no wrong time to participate in a clinical trial, right? At the point of diagnosis, if it's a new diagnosis, you're eligible for clinical trials are available at that point. Whether you've finished treatment and now maybe you're in the survivorship years, there are actually trials that come up for that. For instance, there are new drugs, new pills for breast cancer that we're trying to see if it's better than, say, the tamoxifen that patients are taking now. And the criteria says if that patient has been on it for at least 2 years, which many of these patients are only for years, they're eligible. So they finished all their treatment years ago, but now there's this new drug on the market and you're saying, you could enroll these patients, we want to see. That's available. So at any point, and then unfortunately for patients who may have progressed now to stage 4, perhaps, there we also have clinical trials. And so there is no wrong stage to participate in clinical trials. So the key question is always to ask, am I eligible for any clinical trials? Do you have any clinical trials? And, do you think I would be a good candidate? And where can I find clinical trials? If they don't have maybe, do research in your local area to see if there are any promising clinical trials around that you could be part of. Have a discussion. There is no wrong time to participate.
Okay. And that's why we're having a conversation, because to ask the doctor for a clinical trial as you're going through your cancer will be something new to most of us on the phone. I know when I was going through, I didn't even think about asking. I didn't want anyone to ask me, and I wasn't going to ask them about a clinical trial. But now, just as you're listening today, a clinical trial can be part of your treatment. Just keep that in mind. And then the place that you go for your treatment. I know I work with Somerset, where Dr. Toomey is in Somerville, Dr. Omene is downtown in New Brunswick. They are cancer institutes, and they do have the clinical trials. And I do believe if you go to one of them, or if you happen to go to that hospital, you would be introduced to clinical trials.
And we have another question in the chat from Nancy, if you'd like to unmute yourself.
Yeah, I'm kind of new at this. So I was asking if, well, clinical trials are only done on people that are positive for cancer. So what happens to their treatment? Is the treatment put on hold? Because I used to work in a doctor's office and we used to do clinical trials, and some patients got the real thing, some people got a placebo. So is this how these clinical trials are?
So it's different in cancer, Nancy. It's usually standard of care versus some change to that standard of care. But the placebo trials in cancer are only in the situation where there is no standard of care, right? So standard of care for a certain patient would be no treatment. So there could be a clinical trial saying, well, we might want to do better than what the no treatment arm is. So we can give some of the patients could get a placebo and some of the patients would get the new treatment. But the standard of care is always there. So that's the thing you can be sure of in a clinical trial, that the base is always going to be the standard of care. And that's usually what they're comparing things to. But good question.
Great question. Great question, because the key thing to know is when you say your treatment is put on hold for a clinical trial is the treatment. That is the treatment. And sometimes clinical trials, that Dr. Toomey was saying, is either comparing the standard of care treatment, so they're getting treatment, or maybe in combination with this added drug that maybe has shown promise, great promise. And we had it all the time, a drug that has shown great promise in the stage 4 setting, that we're like, okay, let's bring it forward to the early stage setting to see if we can improve upon survival so that, we can prevent recurrence, right? And so we just want to maybe add it to a standard. So either way, you're not being shortchanged. You're getting the typical standard of treatment, or you're getting something that potentially could then be better, right? And then that's the only way we can answer these questions. But we definitely don't give placebo instead of treatment. That would be unethical. And so we don't do that, not in cancer care.
Well, that sounds even more of an incentive that you may get even a better treatment, exactly. What your standard of care is.
Exactly.
Well, that's exactly the point. And I think we as healthcare practitioners, it's incumbent upon us to explain to patients that that's what we're trying to do. And I think, obviously you listen to your healthcare providers, and you have to trust them. And we have to really tell patients, give them our enthusiasm for these trials. It's always up to you to participate or not. You can always stop anytime you would like. There are many protections. You sign something called an informed consent, and it's all about educating you what the clinical trial is. But, I personally think it's our enthusiasm for the clinical trials. For some of my patients, I remember in the early 2000s, there was a drug called trastuzumab that was in clinical trial as a adjuvant treatment. And I think I had 9 patients with HER2 positive, and I was able to convince 8 of them to join this trial. And then in 2005, when the data was presented at a national conference, 5,000 oncologists got up and clapped, and we don't get up and clap, but we all got up and clapped because the reduction in recurrence was so amazing for these women that, you know, we don't expect people to recur with that disease anymore. We find it very unusual, but at that time, it was just such a wonderful thing. So yes, I push my patients and always have when I think something sounds really good.
That's exactly right. And we have that all, and it's funny you mentioned that, Dr. Toomey, because that's what I was thinking about, trastuzumab. And in the field of HER2 positive breast cancer is an aggressive biology, but we don't worry about that anymore. We tell patients, yeah, it's aggressive biology, but we have great drugs, you'll be fine. Like, you're gonna do really well. It's amazing what drugs, true clinical trials for this aggressive disease that used to have a high mortality rate, it's even better in some cases than hormone receptor positive breast cancer. And speaking about, you know, practice changing treatments, TDXD was the latest drug in HER2 positive breast cancer that received a standing ovation at ASCO, you know, a year ago for that, because of the impressive results. And only clinical trials could we have the data that we can now give a standard of care to these patients and improve upon the survival. So this is important.
It does take some, you know, courage to participate in a clinical trial. And it also takes altruism, right? Knowing that what you're doing, once again, may be helping you very much, but it is certainly going to help the next generation of women. I always say women are standing on the shoulders of the women that went before them who did do the clinical trials. You know, anybody can take standard of care, but to go into something that we don't have all the answers for, that does take some amount of courage. And I have to say that my patients and breast cancer patients in general really have that ethos of trying to help the next generation.
Mhm. And it does. It takes courage. It takes trust. It takes prayer. It takes everything you have when you're going through something like breast cancer to try to navigate that and go the right spot. Okay, Ryan, I think you have a few more questions.
Yeah, we had a couple of comments in the chat from Beverly, from Christine, and I know Mercy had another question. I see Demita has her hand raised. We are closing in to 8:00 p.m. So I think if we could maybe address the comments and then answer the last couple of questions and then move into the wrap up.
There's no question that Bill is not himself. Following Sheila, the dictator's life.
Who was allowed?
I don't think that was a question. Somebody. Okay. I
Yeah.
see the Mitch's hands up. You want to take?
What are the comments? Yeah.
This is Beverly Cooper. I had a comment that I wasn't able to do a trial, but because I was diagnosed and unfortunately had to wait 9 months because my insurance lapsed.
Oh my God.
I got a chance to travel around to many different locations and listen to several meetings. And when going into certain areas, so many were so hesitant about going on trials, but yet and still, I felt almost like an advocate that if you don't think you can afford medication and you don't think that you are getting the right treatment, you become literally a VIP going, that's my nickname for it. You become a VIP going on a trial. And usually the first two things is, well, do you get compensated for it? And, you know, I don't have transportation. So those are the two common things that I hear a lot when reaching out to women who don't feel that they're getting proper treatment from their doctors, that going on a clinical trial will allow you to get such amazing treatment. You get the drugs that will hopefully help you, but as far as the compensation and the transportation, I tell them they're going to have to find that information out for themselves.
That's excellent. Yeah, the care is typically top notch, and you know, being exposed to potentially in groundbreaking treatment for free, because and I think this will also pertain to Mercy's question. getting insurance. So the trial will pay for it. Whatever, all the aspects considered in the trial will pay for it. There are certain aspects of the trial that may be standard of care that insurance should pay for, and they typically do pay for that, right? And the trials can then pick, you know, for some patients who don't have insurance or whatever, the trials can pick up the slack. So out-of-pocket costs is not an issue for patients going to trial, because if you think about it, that would then make patients not go on trials if they have to come up money from out of their pocket. So
yeah, on the other hand, patients are not given a lot of compensation because that's an inducement that is felt to be unethical. So it's not that people get paid for it, but the drugs are free, and any procedures that you have that are above and beyond standard of care that don't go through insurance get paid for by the trial.
So someone's hand up.
Yeah, Demita, would you like to have your question answered?
If I can remember it. I think one of the questions I had was when being involved in a clinical trial, is there any other component besides drugs that comes into play?
So clinical trials could be in radiation therapy, for example, could be surgical trials, looking at better ways of perhaps doing less surgery, or sparing nerves or things like that. So yes, the clinical trials could be, as I said, quality of life. They could be just looking at genomic or genetic blood work. Clinical trials can actually even be just looking at a registry, right? Seeing how people do, because the information about how people do is important. So there are multiple kinds of clinical trials.
Thank you.
You're welcome.
All right, and then we had a comment from Christine.
In the interest of time, it says, I've taken part in a clinical questionnaire, but have not gotten a medical response to the specimen I submitted. So typically there is, when you sign consents for a clinical trial, whether it be the follow-ups or what have you, they typically should tell you in the consent form what you're doing, what you're taking, the expected follow-up. And there's also always a contact information on that form. So I encourage you to maybe reach out to the center in which you did the trial, and once you say the name of the trial, the information is there, and they can sort of pull it up, and the specific contact for that trial to speak to, and then they can help you. If you needed to have an answer based on the specimen you submitted. It's not clear if they expected to reach back to you, or if you gave your specimen and that was the end of it. It really depends on the question you're trying to ask and what the expectation is when you sign the consent form. So, reaching back out to the center in which you participated in the trial for follow-up, just to make sure you don't fall through the cracks in terms of the trial follow-ups, and you commit to doing what it is that you wanted to do. And so just reach back out to them. Another comment says, the primary care provider should be trained and sustained as the first point of screening and referral for recruitment of patients into clinical trials. I completely agree. primary care providers, they would be, a nice entryway to help in terms of referrals to patients, for patients to cancer centers that can offer these patients trials. And so I completely agree with that. And Jackie Jackson says, what I'm hearing is that for the most part is that there is a fear of being a medical guinea pig. Do you think this is the reason why patients are hesitant to participate in clinical trials? Yes, I think Ms. Reed was alluding to that earlier.
Absolutely, yeah. But we have to push past our fear, lean into our faith, and go for it. Going into 2023, we want to see our grandparents and great-grandparents at the Thanksgiving table, Why should our ethnic group be the ones that don't have those older adults with us? So it's just like we said, tonight was open for you to open up, have a conversation with family members. It's a point to start, okay, and find out all the information you can. And that's what this was all about tonight. So we can try to move past some of the fear.
And we all acknowledge the reason why there is this fear. It's historical, it was a tragedy. But also to remember that great steps have been taken so that that is never repeated. We have an IRB. These clinical trials have to be vetted rigorously for safety, for ethics, that cannot happen again. It will never pass the test to be allowed to be open. So we have come a long way. And so there shouldn't be a fear of being a guinea pig, because the times have changed. They had to be changed after the tragedy of Tuskegee and the outcomes. And so that's not what's happening these days. So hopefully the more patients are educated, the more they will feel more comfortable about that.
And I know we're over time, but we did have one more question in the chat asking if insurance is needed for trials.
Actually, not. So actually, from my point of view, if I have a patient who doesn't have insurance, I'm really happy to have them enroll in a clinical trial, because then, quite often that much of what they need can go through the clinical trial. So not as far, insurance is not necessary to be in a clinical trial.
Exactly.
And before we close out, I want to just thank all the sisters from Somerset that joined us. We started a new chapter in Plainfield, Sister to Sister to Plainfield chapter, and I've seen some of the names from that chapter. And this is all about education. What we try as Sister to Sister to bring to our community, to educate our community, so that we can live and have a better quality of life. So I thank all of you for joining us, and it was just my pleasure to be on this panel with Dr. Toomey and Dr. Omene.
That's great. I'm so appreciative. Thank you, Dorothy Reed. And I want to say thank you all to everyone. And as I promised in the wrap up at the end, I wanted to be able to throw up the contact information. Go to the next slide. Oh, this is a summary, which we, in the interest of time, I won't go through this, but this is just to summarize a lot of what we've been talking about why clinical trials are important. And they highlight the key points at the bottom, that they are the key to making progress against breast cancer. In the next slide, I wanted to be able to throw up some contacts for myself, Dr. Toomey, Ms. Reed, for any questions you may have after this evening. And then especially for our health system, there's the clinical trial contact information. Please feel free to call regarding any clinical trial questions you may have. And at the bottom, you can see all the different centers in our health system where we open trials that are open at our cancer center, Institute of New Jersey, are open system-wide. And you can, depending on which center you're close to, you can call these participating sites to ask about clinical trials. So I want to just say thank you to everyone. Thank you to my esteemed colleagues, Dr. Toomey and Ms. Reed, for joining me this evening. And I hope that all of you have gotten some questions answered and better understanding about clinical trials, but more importantly, why it's important that Black women participate in clinical trials, that we can benefit from all of the advancements in technology and research that have come through from clinical trials. So thank you, everyone, and have a good rest of your night.
Have a great evening. Take care.
All right. Good night, everyone.
Good night, Ms. Carthy. Bye-bye.
Bye.